Nevada is prepping for change.
I'm Dr. Joe Iser, Chief Health Officer for the Southern Nevada Health District. The vision of the 5-year plan detailed in the National HIV/AIDS Strategy, updated to 2020, affirms that the United States will become a place where new HIV infections are rare. Today I want to talk to you about pre-exposure prophylaxis, or PrEP. HIV incidence across the nation is declining. Unfortunately, approximately 40,000 people are diagnosed with HIV in the United States each year, and many others are still at risk. While incidence rates in Nevada remain stable over the last 5 years, we are not seeing the same decline that other states are seeing. People who engage in sex without using condoms with multiple partners and people who inject drugs, especially those who share needles, face a higher risk of becoming infected with HIV. While we continue to educate our community about risk reduction and condom use, HIV incidence remains steady and we must begin prepping for a change. This e-learning experience will provide you with opportunities in your practice to prevent HIV by offering pre-exposure prophylaxis to people with a considerable risk of infection. PrEP is a biomedical intervention consisting of a daily oral medication to prevent HIV acquisition. According to the Centers for Disease Control and Prevention, it's more than 90% effective if taken regularly. PrEP is changing the face of HIV. The public health status of our community and the health of our residents connects all of us. With your help, we can reduce the number of new HIV infections. Very soon, health district staff will be reaching out to community providers to discuss the use of PrEP as an effective tool to decrease HIV transmission. During this meeting, we will encourage our community providers to counsel their patients on strategies to maintain a healthy, fulfilling, and worry-free sex life. We will also discuss the importance of routine STD screenings and will be distributing our PrEPing for Change resource kit. This PrEPing for Change kit includes the following resources for your practice: identifying patients who may benefit from PrEP, how to discuss PrEP with your patients, tips on how to take a sexual history, effectiveness of PrEP, patient monitoring, and the importance of adherence. I hope that you'll find this PrEPing for Change kit beneficial to your practice. Thank you, and we look forward to working with you. Now let's get started.
Pre-exposure prophylaxis, also called PrEP, refers to the daily use of antiretroviral medication by people who are HIV uninfected but at risk for infection in order to prevent HIV acquisition. How does PrEP work? Among people who inject drugs, it reduces the risk by more than 70%. The risk of getting HIV from sex can be even lower if the client combines PrEP with condoms and other prevention methods. Risks for other STDs, such as syphilis, chlamydia, and gonorrhea, should also be discussed and screened. For PrEP to work well, it is dependent upon patients taking the medication every day. If taken every day, PrEP reduces the risk of HIV infection by up to 90%. Protection from HIV diminishes greatly with lower levels of adherence. Who can benefit from PrEP? PrEP is only indicated for people who do not have HIV infection. There are 3 groups of people who are likely to benefit from PrEP. Number 1, men who have sex with men, who either engage in condomless anal sex outside of a mutually monogamous relationship with an HIV uninfected sexual partner, or have been diagnosed with a sexually transmitted infection in the last 6 months, or have an HIV-infected sexual partner. Number 2, heterosexually active people who engage in condomless sex with a partner or partners of unknown HIV status who are at high risk of infection, or have an HIV-infected sexual partner. And number 3, injection drug users, especially those who share injection equipment. Other people with a high risk of HIV infection are also likely to benefit from PrEP. Take a sexual history of all patients by asking who, how, what. Who questions include the number of partners in the last year, gender, steady or casual partners, and the partner's risk factors such as multiple sex partners, HIV positive, or incarcerated. How questions include the types of sex such as vaginal, oral, and anal, or sex while under the influence of drugs or alcohol. And the what questions include the methods used by the patient to protect themselves from STDs and HIV, the methods they've used to prevent pregnancy, and their previous history of STDs. When having these conversations about sexual history with your patient, emphasize that this is routine for all patients. Ensure confidentiality. Be non-judgmental both verbally and non-verbally, and make it conversational by asking open-ended questions. What are the risks of taking PrEP? In clinical trials, PrEP was generally well tolerated and serious adverse events were rare. Side effects of PrEP include mild nausea that improves with continued adherence to the medication, a 1 to 2% decrease in bone mineral density without a concurrent increase in fractures, and primarily in patients with renal comorbidities, renal dysfunction that tends to resolve with cessation of the medication. Antiretroviral resistance due to PrEP is rare. Although some people taking PrEP may reduce condom usage, this has not been shown to negate the HIV protective effect of PrEP. Some people complain of gas, nausea, or headache, but these symptoms tend to disappear within 1 month. If they don't go away, have your client call the office. If your patient has missed a dose, have them take it when they remember. Take the missed pill anytime the same day, but do not take 2 pills at once. And it helps to get into a routine by trying to take the pill the same time every day. Set a calendar or text message reminders.
Hello, my name is Rob Phoenix. I'm a family nurse practitioner, a primary care provider, and an HIV prevention specialist here in Southern Nevada. And I've been doing HIV prevention for 4 years, and over those 4 years we've helped hundreds of patients prevent becoming infected with HIV through biomedical prevention programs such as PrEP. Unfortunately, we've also had patients who presented to our clinic who were too late in getting into their PrEP program because they had asked their primary care provider and were told they didn't know what that was, and now we treat those individuals as somebody living with HIV. Over the past 4 years, I've helped to train over hundreds of providers just like you on how to offer HIV biomedical prevention programs such as PrEP. What I hear most often in these trainings is I don't know how to ask patients about their risk, and I don't know how to ask patients about their sexual health, or to take a sexual health history that can help me identify what those risks might be. Your academic detailer has great tools that you can use to incorporate a sexual health history into your practice. The CDC also has great tools that you can download for free on how to conduct a sexual health in your practice. The other concern I hear from providers is how do I add this to my already busy schedule? I have so many things to do in a visit. My answer to you is include your staff. By including your front office staff, your medical assistants, using these tools, they can start the conversation about sexual health history with your patients so that when you enter the room for the exam, the dialogue is already open and they're ready to discuss that, and they can help you identify what their risks are for new HIV infections. Patrick Sullivan and his colleagues from Emory University in Atlanta, Georgia, have done some great work in showing the benefits in real-life data of HIV programs or HIV prevention programs such as PrEP. In their recent presentation at the International AIDS Conference in Amsterdam in 2018, they discussed a reduced risk in HIV infections through PrEP utilization from 15.7 per 100,000 lives in 2012 to 14.5 per 100,000 lives in 2016. Their data also validates what we already know, is that in areas of low utilization of PrEP services, we have higher rates of new HIV infections. In areas of higher utilization of PrEP services, we have lower rates of new HIV infections by as much as a 35-fold decrease in those new infections. Nevada still has high rates of HIV infections every year. In 2016, we had over 450 new infections with HIV in the state of Nevada. That's more than the entire city and county of San Francisco, which is greatly larger in population than the entire state of Nevada. Our communities of color are disproportionately affected by these new HIV infections. Join us in the national campaign of Getting to Zero for new HIV infections. Take steps to offer PrEP in your patient population and to help stop HIV infections. If you're not ready to offer PrEP in your practice, your academic detailer has resources such as preplocator.org they can share with you. They also can share with you providers in your area that can help you with referrals for providing PrEP services for your patients. Thank you for helping increase utilization of HIV prevention services like PrEP. And thank you for taking part of your day to learn about how you can be an important part in helping stop new HIV infections.
How do you prescribe and monitor PrEP? Step 1. Determine eligibility. Document that the patient is at high risk of HIV infection based on sexual or medical history. Assess the patient's ability and willingness to adhere to regular visits, laboratory testing, and daily medication. Confirm that the patient is HIV uninfected by sending a baseline HIV test, preferably a fourth-generation HIV antibody antigen test. All patients should be asked about symptoms of acute HIV infection in the previous 4 weeks. Those who report symptoms should have also had HIV RNA or viral load testing to exclude acute HIV infection prior to the initiation of PrEP. Confirm that creatinine clearance is at least 60 milliliters per minute by sending a serum creatinine. Tenofovir emtricitabine should not be prescribed to those with creatinine clearances lower than 60 milliliters per minute. Assess for chronic hepatitis B infection by sending a hepatitis B surface antigen test. Both tenofovir and emtricitabine are active against hepatitis B. Knowledge of baseline hepatitis B status is crucial, as it may impact the decision to stop PrEP if and when the medication is no longer required for HIV prevention. Consultation with a specialist prior to starting PrEP is warranted if the patient has chronic hepatitis B. Assess pregnancy status in patients with childbearing potential. Step 2. Prescribe PrEP. Clinicians should prescribe the once-daily oral fixed-dose combination tablet of TDG-FTC, consisting of 300 milligrams of tenofovir disopropyl fumarate and 200 milligrams of emtricitabine. CDC recommends prescribing no more than a 90-day supply at a time, so the patients do not continue the medication long-term without appropriate laboratory monitoring. Step 3 is monitor. Send an HIV antibody antigen test at least every 3 months. If there is a suspicion for acute HIV infection at any point, an HIV RNA should be performed. Check pregnancy status every 3 months for those with childbearing potential. There are no known safety concerns with PrEP use in pregnancy. However, data on this subject are limited. Check a serum creatinine after 3 months and, if stable, every 6 months thereafter. Perform an STI screening at least every 6 months. Counsel about adherence and risk reduction at every visit, and reassess the need for PrEP at least once per year. Step 4. Stopping PrEP. If the client wishes to stop PrEP, encourage them to have a conversation with their provider about using other HIV prevention strategies. And step 5 is restarting PrEP. If the client has stopped PrEP for more than 7 days, it's important to get an HIV test before restarting. Report any flu-like symptoms or rashes to their healthcare provider, as they could be symptoms of HIV.
Hi, I'm Dr. Ali Reza Farabi. I'm infectious disease HIV Hep C specialist in Health District Department and Wellness Center, UMC. This is a subject that came in 2012 about the PrEP. It is very interesting that at the beginning we have only 8,000 people on this PrEP. But by a time, based on the data we have it in 2013, over 100,000 people on the PrEP right now. The result, very impressive, because number one, think about it, when you have HIV, this is the disease for the rest of your life. You have infection, and not only infection, you have a lot of comorbidity that carry with you for the rest of your life. PrEP, prevented. What does it mean? It's meaning that with maybe 1 pill a day, you prevent HIV. People with high risk, what does it mean high risk? High-risk people is a group of people has MSM, unprotected sex, and be multiple sexual partner, and also high risk for other STDs. This group of people, with taking 1 pill a day, prevent HIV 96% based on the data we have. We know that a group of people is a high risk for accusation of HIV. One of the factors that is very important to know is history of STD in last 6 months. The people with history of STD has possibility of risk of HIV. This group of people with multiple sexual partner, unprotected sex, maybe is good candidate for this PrEP. Also, we talk about not only this medication for PrEP with 1 tablet daily is, in top of that, we need to talk with the patients regarding use condom to prevent other STDs. But keep in your mind, people with multiple episodes of STD, even one time, they have high risk to get HIV and maybe is good candidate for PrEP. Sexual history very important in some area with high prevalence of STD, like our city, Las Vegas. Based on the data, we been number 1, number 2 in the list of cities in United States for syphilis. As you know, syphilis is genital disease, but can affect from head to toes. This one is any patient with any symptoms, we eligible in this city to ask questions about STDs. Based on the data, we have number of new HIV patients dropped from 50,000 right now to 38,000 in back to 2016. That one tells us 2 things. Number 1, using more HIV medication, and since 2012, we started on PrEP. As you see, the number of PrEP, as we discussed about it, it was from 8,000, or about 8,000 in 2012 to more than 100,000 to 2017. Based on the data, is significant drop of number of new diagnosed in some of the cities we have high prevalence of HIV, like San Francisco. Number of new patients in San Francisco significantly dropped because of these 2. Any of your provider even ask about sexual history, high-risk people, and maybe your patient is good candidate to start on PrEP and decrease the chance of HIV in future. Who's on risk? Definitely MSM people with multiple sexual partners. Any STD in last 6 months. Unprotected sex with multiple sexual partner, and even in heterosexual people with high risk area, they're gonna be good candidate for PrEP. Treatment is 1 pill a day through WADA for 90 days, and you risk evaluation after 90 days. Let's work together to lower the rates of HIV in Nevada. Let's PrEP for change.
How does post-exposure prophylaxis interface with PrEP? Post-exposure prophylaxis, also called PEP, refers to the use of antiretroviral medication for 28 days following a discrete exposure to HIV infection, such as a condomless sexual encounter with a person known to have HIV infection. PEP must be started within 72 hours of the exposure and consist of 3 drugs. PEP regimens recommended for use in the United States include TDF-FTC with dolutegravir or TDF-FTC with raltegravir. PEP and PrEP may interface in 2 ways. Number 1, patients who present seeking PrEP may meet indications for PEP. For example, a male patient seeking PrEP who reports during his initial evaluation that he engaged in condomless anal sex with an HIV-infected man 1 day prior could benefit from PEP before starting PrEP. And number 2, patients who present seeking PEP may be at high ongoing risk of HIV infection and thus may also benefit from PrEP. In this instance, PrEP can be initiated as soon as the 28-day PEP course is complete, assuming the patient remains HIV uninfected. Patients who are prescribed PrEP and are adherent do not require PEP if they have a known exposure to an HIV-infected individual, unless that individual is known to have HIV that is resistant to the medications in PrEP. Who can prescribe PrEP? Any licensed medical practitioner can prescribe PrEP. Infectious disease specialization is not required to prescribe or monitor PrEP. PrEP is about prevention, which is a function of primary care. Primary care clinicians can play a key role in ending the epidemic by screening patients for eligibility for PrEP and prescribing it when appropriate. How do I code and bill for PrEP? ICD-10 codes that can be used for PrEP include Z20.6, exposure to HIV, and Z20.2, contact with and suspected exposure to infections with a predominant sexual mode of transmission. PrEP baseline with or without insurance, Z11.3, Z11.4, and Z11.59. Clinicians can bill for PrEP visits using CPT codes for prevention counseling, for example 99402 for a 30-minute prevention counseling visit. Is PrEP affordable? TDF FTC is too expensive to buy out of pocket for most patients. Commercial and governmental insurance varies with regard to coverage of PrEP. Currently, the manufacturer of PrEP offers a patient assistance program that covers the cost of the medication for those who are uninsured or underinsured. In addition, many states have developed drug assistance programs for PrEP. Payment options for PrEP include private insurance, Medicaid, and PrEP assistance programs, such as Advancing Access and the Patient Access Network Foundation. Both of those can be reached by dialing the numbers shown on your screen. In conclusion, let's recap 3 steps to PrEP. Number 1, determine eligibility. High risk of HIV based on sexual and/or drug use history. Negative HIV antibody antigen test and no symptoms of acute HIV in the prior 4 weeks. Serum creatinine to ensure the estimated creatinine clearance is more than 60 milliliters per minute. A hepatitis B surface antigen to assess for chronic hepatitis B infection, and a pregnancy test for those with childbearing potential. Step 2, prescribe PrEP. The once daily combined dose of 300 milligrams of tenofovir disoproxil fumarate and 200 milligrams of emtricitabine, and no more than a 90-day supply of medication at any given time. And step 3 is monitor. HIV antibody antigen test every 3 months. Pregnancy test every 3 months for those with childbearing potential. Serum creatinine at 3 months, then every 6 months if stable. Screening for sexually transmitted infections at least every 6 months or when deemed necessary. Risk reduction counseling at every visit, and reassess the need for PrEP at least once per year. If you would like more information or a staff training, call one of our Southern Nevada Health District PrEP navigators at 702-759-0546 or 702-759-1228. Additional resources are available at the links on your screen. Thank you for joining us as Nevada is prepping for change.